Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Some hand and wrist conditions can be treated with microsurgery. We'll hear all about it from orthopedic surgeon Saeed Mohammad. He's an assistant professor of orthopedic surgery at Upstate who specializes in wrist and hand surgery. Welcome to the Informed Patient, Dr. Mohammad.
Thanks for having me.
Before we get into the specific conditions, what's a good overall description of what microsurgery is?
Microsurgery is pretty literal. It just literally means surgery under a microscope. And so it's used to treat problems that are on a very small scale, but they can often be very big problems. And so the fact that we're repairing things under a microscope doesn't necessarily mean that it's a small problem. Usually, actually, if we're repairing something under a microscope, it tends to be a bigger problem. So blood vessels, nerves, things like that.
So it's vessels and nerves as opposed to bones?
Correct. Yeah. You'll almost never see somebody repairing a bone under a microscope.
Interesting, because I think of orthopedics just working on bones, but you work on everything in the area too, right?
Yeah. The field of hand surgery is specific within orthopedics, probably apart maybe from spine surgery too. Those are the two fields within orthopedics that use microscopes. Otherwise, microsurgery is a subspecialty that probably mainly is seen within plastic surgery. But within hand surgery, we do a lot of microsurgery, and there's a lot of overlap too. So people can go into the field of hand surgery from either orthopedics or plastic surgery. And here at Upstate, we actually have both within our hand division.
Well, if it's microsurgery, does that mean that the recovery is going to go smoother for the patient because you're working on a smaller area?
The recovery actually doesn't really have anything to do with how we do the surgery. It's pretty standardized whether or not you get microsurgery. Now, if we're talking about repair of arteries, that's something that recovers essentially right away. If we're talking about repairing or reconstructing nerves, that's something that can often take a long time. And so it matters really less how we do the surgery rather than what we're doing the surgery for.
If you're working on nerves, is postoperative pain a bigger issue?
Not necessarily. I would say that a lot of my patients complain of different kinds of pain following a nerve repair as opposed to, say, like a fracture repair. And so that'll be like some of the things that sound more like nerve pain, and people who have pinched discs or things like that can attest to how these things feel. But things more like burning or stinging, that kind of pain, those are common to have in the early period after nerve repair, but they can often indicate nerve recovery. And so I do tell my patients that after I repair a nerve, if they're feeling some kind of strange sensations, then oftentimes that can be normal and a sign of the healing process.
Now, what about physical therapy? Is that something that is common after microsurgery?
Not generally, in my mind. The main goal of physical therapy is to restore motion. And so when you're repairing arteries and nerves, motion is less of a concern. Obviously, if you have an area of the body where the nerve hasn't been supplying the muscles in that area for a long time, those kind of patients can benefit from physical therapy. But where I usually see my patients who I send for physical therapy is when I do fracture repair or tendon repair, which generally don't require a microscope.
Well, let's talk about carpal tunnel syndrome. Can you describe what this is and how surgery may help?
Yeah, so there are two main motor sensory nerves that supply the hand. There's the median nerve and the ulnar nerve. The median nerve, as it gets to the wrist, travels in a discrete area called the carpal tunnel. And there's some anatomic boundaries of that at the wrist. And at the top of that tunnel, there's a thick ligament. And so in many people, particularly after years of living and using your hands, that ligament can thicken and the area in the carpal tunnel can decrease for different reasons. And when that happens, then that nerve gets pinched. And so what that usually looks like initially is decreased sensation and some tingling in the thumb, index, and middle fingers most commonly, but it can vary as far as what the involvement of the fingers is. And as it gets more severe, it can progress to painful sensations as well as some weakness in the muscles of the thumb.
Now, how often do you see this in patients?
Very, very commonly. I think probably carpal tunnel syndrome is the most common thing I see. I'm doing a carpal tunnel release today. And so if I am in the operating room, there's a chance that I'll probably be doing a carpal tunnel release that day. And so it's probably the most common condition that I see.
Are we seeing more of these with the rise of texting? I mean, people are using their phones all day. Does that contribute to carpal tunnel?
No, 20 to 30 years ago, there was a popular kind of adage where typing caused carpal tunnel syndrome, and they did a lot of studies on this and actually hasn't really been found to increase the incidence of carpal tunnel. the carpal tunnel is occupied by the median nerve as well as the flexor tendons that help bend your fingers down. And so theoretically, I think that's why people thought maybe that would be causing increased carpal tunnel when computers started becoming more popular. But the only thing that's really been borne out to worsen carpal tunnel from an activity standpoint is repetitive, heavy gripping activities. So I see it in patients like my plumber patients and construction worker patients and things like that. As far as texting, I think the texting itself probably isn't an issue, but when you keep your wrist in deep flexion or deep extension, that can often exacerbate carpal tunnel because that increases the pressure within the carpal tunnel. And so one of the first treatments for carpal tunnel is I give my patients splints to wear at night. And what that does is it keeps the wrist in a good position, preventing you from those deep flexion positions. And a lot of times that can help decrease symptoms, often to the point where patients won't require surgery for a while.
Once the surgery does take place, does this offer lifelong relief or does that ligament ever thicken again?
There's always a risk that carpal tunnel can recur. If the surgery is done appropriately, then recurrence doesn't happen for 20 to 30 years. And so it's a really successful procedure. And even recurrence itself is extremely uncommon. I think I've done maybe 2 or 3 revision surgeries in the last 3 or 4 years. So it's very, very rare. Where you'll see it is sometimes you'll see an incomplete release, meaning the ligament that we talked about earlier hasn't been completely released in surgery. And in those patients, the symptoms will recur much quicker. But if you're seeing a true recurrence of carpal tunnel syndrome, often it will take 20 to 30 years.
Well, what can you tell us about trigger finger?
So trigger finger is a similar sort of condition to carpal tunnel syndrome, except where carpal tunnel syndrome affects a nerve, trigger finger affects a tendon. And so the tendons that help you bend your fingers down, they're called your flexor tendons, and they travel in a little tunnel once they hit the finger. And that tunnel helps keeps the tendon down to bone when you flex your fingers. And the tunnel starts in the palm right proximal to the fingers, so right before the fingers. And the entrance to that tunnel, sometimes the tendon has trouble passing through for one reason or another. Usually there'll be a little thickening of the tendon, and then you'll start feeling clicking and locking of the finger. And in some patients, it progresses to the point where their finger stays locked down and they have to use the other hand to open it back up. And so that's a condition called trigger finger.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking about hand and wrist surgery with Upstate's Dr. Saeed Mohammad. Now, osteoarthritis is a common issue for people as they age. What can be done to help if arthritis in the hands is causing pain or making it hard to use the hands?
So as with everything, I like to start with conservative treatment. The hand joints that are most affected by arthritis are at the tips of the fingers and at the base of the thumb. And so those joints are all very superficial to the skin. So as a first line treatment, I usually recommend either immobilization if it's the base of the thumb. And in my clinic, I have flyers for several different kinds of splints that patients can try. And then over the counter pain medication and things like Voltaren gel, which is a topical cream that has non-steroidal anti-inflammatory drugs in it. Those can be really successful in the hand because the joints are so close to the skin. So if you put some medication on the skin, oftentimes it'll diffuse down into the joint. Following that, we usually try a corticosteroid injection into the joint that's causing problems. And the tips of the fingers, that's a little bit difficult because the joints are so small. And then surgery is usually reserved as a last option. And so the surgical treatment for different joints is different. But overall, you're either trying to replace the joint or fuse it.
And that will take care of the issue?
So the idea is that it takes care of the pain. A lot of people will experience restriction of motion from arthritis. And so in the tips of the fingers, the surgical solution is fusion. And so that won't solve the restriction of motion. It'll actually make it worse. But the idea is that we do the surgery for pain.
I see. Now, I've heard Dupuytren's contracture, but I'm not sure what that is. Can you explain that?
Yeah, so Dupuytren's contracture is a congenital issue. It's a thickening of the fascia in the palm, and fascia is a very thick tissue that lies under the skin. And in some people who have a genetic predisposition to this issue, that tissue will thicken. And the first stage of that looks like little bumps in the skin. And as it progresses, the condition can actually bend the fingers down and they stay contracted down. And so when that happens, we have a quick and dirty test that we do in hand surgery where if you can lay your palm or hand flat on the table and your fingers can go straight, then generally you don't require any surgical intervention. However, when your condition progresses to the point where your fingers bend up and you can't get your hand flat on the table, that's when we consider surgical intervention. And there's a couple of different kinds of surgeries we can do for this condition.
So, do you remove some of that tissue?
Yeah, it depends what kind of surgery it is. One of the surgeries I do is called a needle aponeurotomy. And in those patients, there's a very distinct cord or a kind of like a rope that goes up to the finger. and you can see it through the skin. And so I take a needle after numbing up the skin over the cord, and I just literally poke through the skin and pop it until we can straighten the finger out. And in those cases, I don't remove any tissue. Now, the classic surgical treatment for Dupuytren's contracture is called a fasciectomy, where you open up the skin and then you literally cut out as much of the diseased tissue as you can find.
Does it grow back?
Always. Unfortunately, there's no surgical solution or any solution that is completely curative for Dupuytren's contracture. The rates of recurrence are a bit different depending on procedures. About 10 to 15 years ago, an injection was developed for Dupuytren's contracture called Xiaflex. And that's a medication that you inject into the skin and the fascia. And then you bring the patient back a day or two later, and you can literally pop the cords open. The problem with that is that there's been more recent literature that suggests that there's a high rate of recurrence with that. And so there's some debate within the hand surgery world about how much Xiaflex we should be doing.
Now, let me ask you, do you use microsurgery for fractures of the wrist or hand?
No, bones are nice and big, and so I don't need a microscope to see anything there. The microscopes are usually reserved for nerve repair reconstruction, arterial repair reconstruction, and things on a very small scale. Bones, you don't need that. I will say there's a caveat to that. So almost every surgery I do, I wear loupes, and my loupes can magnify things 3.5 times. And so there is some magnification involved, but not with a microscope.
Tendons, blood vessels, nerves, do those become an issue when there's a fracture?
Sometimes they can in really severe cases. And so, for instance, if you have a patient who was in a motorcycle accident and the bone is broken and the energy of the trauma was so much that the bone comes through the skin, things like that, that's when you become more concerned that there could be a potential nerve injury or arterial injury, et cetera. I will say it's pretty rare, but it does happen. And Upstate is a very busy level 1 trauma center. And so those kind of things we do see not infrequently.
And those are mostly emergency or at least urgent surgeries?
Correct. Yeah. So those are ones that are usually going to be done at the downtown campus.
Now, are hands or wrists put in a cast while the bones heal?
Yes.
So immobility is going to help the bones grow back?
In general, stability is required when you want a bone to heal. And so if a bone is broken, but it's still in good position, we can treat it only with a cast, doesn't necessarily need surgery. In those cases, patients tend to do very well. When the bone is out of place, oftentimes we'll do surgery because we want to put the bone back in place, and we don't feel that we will be able to without making a cut in the skin, getting down to the bone itself. Now, when we do that, we usually fix it. And in the case of the wrist or a distal radius fracture, we'll use a plates and screws. And that's like having a cast right down onto the bone. And so that'll prevent it from moving and offer the most stability that we can impart to it.
Do you see more of these sorts of injuries in the winter from people slipping and falling on ice?
Distal radius fractures have what's called a bimodal distribution, which means that there's two populations who generally experience them. There's younger patients with high-level activities, so you have your young patients on motorcycles, snowmobiles, et cetera. And then you have your sort of older patients, a lot of times older women, because the bones get a little bit brittle after they go through menopause. And so those are low-energy activities, so slip and fall from standing kind of things. And so given that there's that bimodal distribution, I'll say that I see a lot more younger patients with distal radius fractures in the summertime and probably a lot more older and geriatric patients with distal radius fractures in the wintertime.
How's the recovery for both of those types of patients?
In general, the bone itself takes about 6 weeks to heal, no matter how old you are. If you have medical issues, like, for instance, diabetes, if you smoke cigarettes, it'll take the bone a little bit longer to heal. But overall, people with distal radius fractures, they tend to have a similar recovery, actually.
Well, thank you so much for making time for this interview and telling us about hand and wrist and microsurgery.
No problem. Thanks for having me.
My guest has been Dr. Saeed Mohammad, an assistant professor of orthopedic surgery at Upstate, specializing in the hand and wrist. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Spotify, Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.